So we are on week 8. It's going to go by quick. Next week, you're going to have your reviews again. I've just got them back from everybody. They're Wednesday, Thursday, Friday, and Saturday, all different times. Mine is Thursday at 2. As like you know, I will make sure that you all have the recordings, and I'll have it on a recording page with all the information. I'm just right now looking at the study guide, making sure the study guide is exactly what you need for the exam, and making sure those big concepts were covered. So probably Friday, you'll have that up, if not slightly earlier. So this week is GI and GU. There are quite a bit of diagnoses that y'all have never heard of. There are many diagnoses that adults don't have. So that's one thing I enjoy about pediatrics, is showing you these differences as a nurse working in an emergency room, trying to pick out these diagnoses and, oh, that must be this, or this is a that, because a lot of them are an emergent where we do see them. So we do have that clinical pediatric assessment thing that's due. Make sure that you have it cleared through me. It doesn't have to be on the list. It can be any diagnosis that is could be a child's. So be creative with it, okay? And then we do have your assignment exam. It's a HESI case study type thing. And then you have the NCLEX questions that are due. Next week is that dosage calculation. It's open. You could start it, look at it. The book is in your vital source. I've had those questions already come up to me, so I'm letting you know. Now, on that quiz, there was one question as I was looking at them, and I wanted to quick, cover it for you again. When you are in DKA, your blood sugars, yes, they're very, very high. Your first job is not insulin. You need to give fluid. You need to dilute it. Then you're adding a slow, continuous, regular insulin drip. Okay? Now, yeah, you can give insulin, but it's not going to bring it down as quick as that dilution. Okay? So dilute and the insulin. So remember that one. You're going to see it again. It's on an exam. When I saw that coming up, that's why I wanted you to know about that. All right, let's go ahead. Let's start with the PowerPoint again. If you're not understanding, please stop me, and I'll explain it a little bit better for you if that's what you need. Now, I do change up the chapters. I think that GI has a little bit more diagnoses that are different. So I start with chapter 45 with your GU, and then I go to 41 and do GI. So that's why it's differently. So when you think about genitourinary tract, GU problems, children, number one is that urinary tract infection. A lot of it is potty training, wiping the wrong way, not drinking enough fluids. In your young boys, especially the ones that are infants that are not circumcised, if mom doesn't pull down the foreskin and clean under there every day with a bath, it is called schmegma. It is like a petri dish where bacteria will grow, and it will go up, climb down the urethra and into the bladder. And we don't want that. So we have to pull it and clean it well. Many parents think they're hurting their child. So that's why there is a high incidence of boys that are uncircumcised. Just as a little ad lib to that, my boss at work, phenomenal nurse, had a boy, and I had to go. We live close to each other, thank goodness. Bestest of friends. I had to go over and pull her child's foreskin down and clean it every day for her. She just couldn't do it because she thought it hurt him. So I understand other parents do the same. It's just, I still to this day think he's funny that I had to do that. Another thing, remember urinary tract, make sure the child finishes the whole dose. Some kids don't like medicines, and it's a struggle, but it's really important. So how do we know a kid's having a problem with, a urinary tract infection? Well, if they start being incontinent and they haven't been, they're potty trained, something's going on. That smell, that strong, foul smelling, I say that wiggling, that redness, their hands in their diaper and their underwear, it's telling you there's something going on and it should be looked at and inspected. So our biggest thing is to prevent urinary tract infections. So again, increasing fluids is the biggest number one to prevent them. Of course, parents knowing when to catch early what's going on with these urinary tracts, and also simple hygiene front to back. And we say that actually little girls sitting in bubble baths actually is not good, because that they're sitting in the water and there's a very short open urethra, and it can pull in that bath water, which can be dirty, and go into the bladder, and again, causing urinary tract. The adolescent, we need to teach them to urinate right after intercourse, especially if we're seeing them frequently for urinary tract infections. Now, how to do a culture, and they're all different. So we've talked about infants, we should do a catheterized specimen because they don't have an immune system and we want to get the correct bacteria the first time. So not all children can we get a catheter in. What about a little 600-gram urinary tract, it may be infection, premature infant? Well, they're showing signs of sepsis. We're going to be doing a urine CNS, but we actually do a suprapubic aspiration. They take a needle right above the syphilis pubis, and they put a needle in it, sterile gloves, clean it well, put a needle in, and get just a little drop of urine, maybe a half an ml. That's all it needs. And that could get a good specimen because there's no catheter small enough. Sometimes we've got to go into the kidneys to get a specimen. Sometimes we need to put a catheter in and whoosh up what's going on, maybe debris in the bladder, and looking that, maybe that's holding an infection. Of course, any ultrasounds, structural could be going on. That's why we do voiding cystourethropographies, looking is the flow going backwards. Is it going from the bladder, going up the ureters? Is it getting into those kidneys? And that's something that's done at your 2 to 3 year old kids that are having frequent UTIs. And then, of course, IVP, I always correlate that to the older child having a kidney stone. So there are things that can happen to a boy and the foreskin when they're young, of those that are not circumcised. So phimosis is when, and you can see just the tip of the foreskin there underneath the picture there, and it's tight and it don't want to pull down. That is called a phimosis. The problem with phimosis, again, can cause it to get swollen and then urine that's dirty to dribble back in to the bladder and cause an infection. So it's something that if a child is having this narrowed of a foreskin, they're going to have to do a circumcision. Sometimes if they've got time to wait, they'll say, let's put a little steroid cream, let's shrink the tissue, let's see if that can make the foreskin pull down. But the foreskin can trap the urine in there. Another thing that can cause that foreskin getting inflamed, and that's called a balantitis. And it's red, it's swollen, it's an infection. It requires antibiotics. So we can have the foreskin half full down. That's a paraphimosis. We can have it all the way up, tightened. That's a phimosis. And then the inflammation of the foreskin is called that balantitis. Again, all about hygiene, washing it, pulling it down with every day in the bath. Another thing is a hydrocele. And this is water around the testicles and the scrotum. And it actually hurts. Now, many times, if there's an infection or showing it, of course, antibiotics will be given. We, as infants, will wait, making sure that that urinary tract system is going to figure it out, and we'll get that collection of fluid and get rid of it. So usually within 12 months, that could happen. Now, sometimes we have to do surgery. Now, this is talking just about external defects of urinary tract, but it's any, not just hydrocele. There's more coming up. Any surgery on the urinary tract in the perineal area, we don't want any sort of damage and rubbing from playing. Children love to play, right? So this is one that you're not going to let them get on a wooden horse or a horse and try to straddle it and jump and run around with it banging that area, because it could cause problems, right? And this is something that I think as nurses we forget. As he wakes up, then he's running. Just make sure that you have that protected. No throwing balls, that could hit him in that area. And of course, no getting on stuff, straddling chairs, toys, whatever. And they usually, because they want to protect the bladder, they usually say bathing maybe in about 3 days. Again, they're trying to protect any sort of infection. Now, cryptorchidism is when the testicles, one or both, fail to distend at all. Some of them, when we see it, we'll see one in and the other one trying to get there. That's usually it. They're usually in the abdomen or in the canal, or we can't find them. That topic. So many times we can wait. They say before 1 year, you must make sure you have testicles and get them down. They say that they stay up within the body too long, the sperm will die and they'll become sterile for the woman, so they'll not be able to have children. So checking for testicles is really important. So one of the ways to check testicles is to have a child in a warm room or leave that warm diaper on until right before the doctor comes, because it keeps the warmth, keeps the testicle dropped. When testicles get cold, they'll tend to, withdraw and pull in. And we want to get and making sure we're seeing testicles. So again, the whole big thing with it is getting the testicles into place so that the sperm will be good and we don't have any infertility because of that. Now, there's a couple different external defects. Hypospadias, epispadias is basically a hole that's not on the end of a penis. Hypospadias, hypo, underneath, is anywhere from the tip down, and there's no hole on the end. Epispadias is on the top. The hole isn't where it should be. So our goal is to get it to the end. Now, usually we're going to go and do a surgical correction somewhere before a year old. The thing with this is we have to have the foreskin. So Jewish faith and the brie or brisk, whatever they call it, they can't do it because we need the foreskin. Because if you look at that picture, that is incision from the tip of the penis down. They fillet it open. And then they use the foreskin to do a plastic closure. And as they close it, they put a catheter in there to maintain the lumen and the hole of to make sure your urethra is up the end of the penis. Now, we try not to do these too late because toddlers are, and that area of children are worried about castration and mutilation. So you don't want them to have bad feelings about their body parts. Now, this is the epispadias. And again, it's on the top of the penis. But with epispadias, there could be all different things. The bladder could be open a little bit, or we could have just urethra open, meaning depending on where the opening. But this is the top, not the bottom of the abdominal wall. This is why they call it's an abdominal wall structure problem. The midline doesn't close, and some of the body parts come up. And again, epispadias, we're going to take and fillet it open. We're going to put a catheter in there, make that nice tubule from the end of the penis so that urine drains properly. We're going to use that foreskin, and we're going to also take and put a catheter in there to hold it open. Again, the biggest thing with, let's say you're born, not just an epispadias, you have also maybe a little bit of your bladder out there. Bladder exstrophy is what that's called. The bladder, everything works right. It's just not formed correctly. It hasn't got in the body yet. So our biggest is to preserve the tissue around underneath the abdominal wall and to prevent infections of that outside body part. What they'll do after the surgeon comes, they'll look and start making like space inside the abdominal cavity to push it back in. And usually they do well. So again, it's preserving tissue and it's preventing infections. Again, this is what the penis could look like immediately post-op. That's the type of catheter they would put in there. So what is our management? Well, this kid's not going to be riding on a rocking horse, right? This is another one that we'll be protecting it because they go home with a catheter in. The catheter is there for up to like 2 weeks. Make sure the catheter is within a diaper because it will squirt everywhere. It does drain urine. So that's one thing to keep an accurate-ish type of urinary output. And then, of course, looking for infection. Is the wound okay? Watching their pain. And then when can they start to bathe, et cetera, et cetera. And do we need to do anything to it? Or is it just soap and water? Is there any antibiotic ointment? All of those things the physician will come up with. Now, sometimes we have to do a renal biopsy. Could be due to chronic renal infections, kidney infections, or it could be, maybe there's a tumor, something's going on, they need to do a biopsy. Well, in older children, they can just do ultrasound, clean the area, and usually with a needle, do a little needle biopsy. In infants, that kidney's so small, they have to cut it a little bit. So a little surgical incision will be there. Now, it's very similar to cardiac cath. Your NPO before, these children will be pre-medicated. And when they come back, just like that leg, that femoral arteries, we have to be careful about bleeding, pressure dressing, or pressure bag. We need to be monitoring that back dressing. Is it oozing urine or is it oozing blood? So we'll be monitoring their abdominal girth. We'll be monitoring the tenderness. Is urine, blood oozing in there? And we'll be monitoring that dressing. And also these children in bed, just like cardiac cath, 24 hours. Like I said, there can be obstructions anywhere. And this is the picture out of your book. The one mention I want you to say about this is the bladder is called a vesicle, okay? That's a difference of thinking. So we have the ureters and we have the vesicle. So when we talk about any sorts of backward flow, it's vesicle ureteral, reflux, okay? From the bladder to the ureter. It could be one side, both sides. It could be a stenosis. It could be a complete not opening. It could be all of the above. And again, a lot of times we find these things out is because of these urinary tract infections. Now, nephrotic syndrome. Now, nephrotic syndrome, I'm going to say this 3 times, has nothing to do with kidney failure. This is not kidney failure. The kidneys are working. What is the problem is the kidneys say, yuck, protein, I don't like you, and all your protein is spit out in the urine. So what are you going to see? Well, you're going to see protein in the urine. You're getting rid of it. Where else is there protein? Or albumin? It's the same name. The albumin in the blood, the protein that carries the medication, the drugs around, is gone. It's very, very minimal. So dosage of medications, you got to be extremely careful because it will be all, free drug in the blood because there's no protein. So hypoalbuminemia. Also, there'll be some issues with your lipids. And because of this disturbance of the fluid in the blood, fluid is pushed into the tissue. What do you see? This generalized edema on these children. You'll even see it in their lips and their gums, and these children don't want to eat just because of the swelling there. They lost all of their protein. These children are something that this is not a cure, it's a lifelong condition, and they're immunosuppressed and they are at high risk for infections because they are holding on so much fluids. What are the big things we do for fluid and watching it? We're going to do intake, output, daily weights, monitor fluid, or probably fluid restrictions and salt restriction. All children, adults, fluid problems, those are the things we're going to be watching really closely. And as children, not to have the salt shaker or eat certain foods, it's difficult. So the family's got to be involved with this. So again, we are losing protein like crazy. All the fluid is in the tissues. We want to reduce that. That's our goal. Our treatment is corticosteroids. And as long as we are compliant, we can keep these children without gaining all of this extra fluid with them. And of course, keeping them from getting sick. Now, that's like a double-edged sword. Nephrotic syndrome, you're immunosuppressed, you're apt to get infections. Now you're on steroids, which make you immunosuppressed too. So you can see you've got to be careful with these children. Again, our priority, intake, output, daily weights. And because they're holding fluids, fluid restriction. They're not urinating. This is the one that we're also going to have a salt restriction. Now, we mentioned one condition that was caused by a strep infection that wasn't taken care of completely, or didn't go away, or didn't treat it at all. And we know that's a rheumatic fever, right? That's strep. Well, acute glomerulonephritis is your second one. This is also caused from a strep infection that wasn't treated the way it should be. What do we see with acute glomerulonephritis? Well, all of a sudden, these children stop urinating completely, almost nothing. And of course, all of that urine, that fluid is somewhere. So these ones you're going to see, that via edematous is going to have those all around their eyes are going to be just swollen up. It has to do with kidneys, so hypertension. Of course, that periorbital edema, right? Headaches because of this hypertension. And blood pressures need to be really closely monitored on a child with acute glomerulonephritis. They'll have hematuria and they'll be losing protein also. So when we figure out that it was due to a strep infection, we're going to be treating it with high dose antibiotics, and hopefully we can get rid of it, and it's going to be an acute stage and not be chronic. Although, if we've been working trying to get this glomerulonephritis under control, and it's not going under control that quickly, it could develop to be chronic, which means for lifetime you'll be with a chronic glomerulonephritis. So again, fluid balance problem. What are we going to look at? Well, of course, managing the edema by monitoring daily weights, accurate intake output. Because it's kidneys and it's the abdominal area, abdominal girths. Again, low sodium and fluid restrictions. And as I said, these will be susceptible just like our nephrotic syndrome. We've talked about Wilms tumor already. We know it's a kidney on the kidney tumor. And we know that we don't palpate that abdomen. That's your big thing with it. Renal failure, acute or chronic. Acute renal failure, which means something happened that caused your kidneys to stop working. I mean, the biggest number one thing is dehydration. Children, dehydration, don't tolerate it, and their kidneys will shut down because they are trying to suck all of the fluid they can and not get rid of anything. So we have to be cognizant of that. If we have a child who's presenting with dehydration, make sure we get that fluid balance up quick. We know it could be kidney disease, obstruction. Yes, that can cause it. And then we also have chronic I'll go into some things there. So, as I said, acute renal failure, what are you going to see? All the signs and symptoms of renal failure. All of a sudden, you're not urinating the way that you should, and then you're going to go into that metabolic acidosis. Your potassium's going to be held on. All of those things you see with chronic, you're going to see it with the acute. And as I said, this is usually due to severe dehydration. Now, chronic renal failure is you already have 50% of your renal function is not working. So you're still holding a lot of fluid. Now, it progressively gets worse and worse, okay? So what is the cause of chronic renal failure? Well, it could be those obstructions, those kinks causing, urine to go back and flood the kidneys and damage them with infections. It could be hereditary. I used to work as a clinical instructor, and the floor that they sent me to was the GU floor, which also had their dialysis unit. And I said to the nurses, how come there's so many kids with, these chronic, kidney failure and requiring dialysis? And what they said was, yes, you have this stuff that's due to congenital malformations, or infections, but a lot had to do with marriages within families. They told me that was causing them to have problems with their kidneys. So I was like, okay. Another thing is that chronic glomerulonephritis. You don't treat a kidney, the kidney is, not working the way it should. Again, that'll make the kidney go into failure. What about you go have an anaphylactoid moment, right? Anaphylactoid purpura. You have literally, gone in and through this allergic reaction have killed your kidneys. And lupus. What does lupus kill? All the organs, right? So, yes, it's one of them it can do. So, chronic renal failure, we want to get that kidney, whatever it has left in it, let's try to get it working. That's maintaining fluid, electrolyte balances the way they should. We give erythropoietin sub-Q injections to help with the red blood cells, which is hemoglobin hematocrit, to decrease the amount of transfusions. And of course, these kids, they're on a machine quite a bit. It's hard to be a normal child, but to promote as much as possible, to try to let them be normal. Now, another way to give dialysis through any age person, actually, but infants can only have peritoneal dialysis. When you talk about a child born, let's say they had prune belly, that's a great diagnosis. Prune belly, they're born, their kidneys aren't working. So they're going to require dialysis or transplant eventually. So these children cannot be on hemodialysis because the amount of blood turbulence going in and out on a machine creates too much flow in the brain and actually causes the vessels in the brain to explode, and they have all of these interventricular hemorrhages and can create more problems down the line. So only choice is peritoneal dialysis. Today, they actually are using peritoneal dialysis as the beginning mark of, adult dialysis. They're not going directly into hemodialysis. They're trying to let them do it. And the reason is because they can do it when they're asleep at night. And that's the way we do children. So there's a catheter. We put it in the peritoneal cavity. Everything we do and open it must be sterile, sterile, sterile. That is all you have. It's the only kidney you have. You must protect it like it's the only thing in the world that matters. And I've seen parents do amazing jobs with it. There is a machine that they hook up. This warmed liquid goes into the peritoneal cavity, whatever quantity the doctor says, 100, 200 mLs. It's about all. It sits there for a while, so that's we call a stay. And then it drains for 20, 30 minutes. And overnight, they do 8 to 10 cycles of it. And at the end of the night, you measure what is in the Foley catheter bag, because that's the end of the system. And what fluid you gave in minus how much is in there is your urine output for the night. And then the kids during the day have a normal life because they do it at nighttime. Now, one of the things I've said is the whole thing is protecting that abdomen infections. So, what would we as nurses be looking for? Well, if there is any change in color or you start seeing some sort of debris in that fluid coming back, that is giving you heads up. I need to call that doctor right now. Yes, he's going to give antibiotics, but you as a nurse need the order. So you need to call the doctor and get the order, and they could be on top of it. And it's great because these children, I've seen parents do an amazing job. This little boy, probably one of the best outcomes of peritoneal dialysis and prune gut syndrome was the name of it. And this child now has his kidney. He finally got his transplant. The child never had an infection. And the mother did every single one of those treatments all night long. And her dressings were beautiful. I mean, this kid came in, kidneys are dry skin. This child was always lubed up and crisp and clean. Best thing I've ever seen. So, what best describes acute glomerular nephritis? It's just like rheumatic fever. So, it's after a strep infection that wasn't treated. And how would you know a strep infection if we had no history? We can do that ASO titer, remember? The anti-strepolithin titer is strep in the middle. And if it's positive, you know you've had that strep infection, and that gives you that, okay, we're treating. Okay, here we go. The GI system. Remember, it starts with the mouth and it goes to the anus and all the things that hook up in between. So the first thing we think of with the mouth is nutrition, 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 right? We know there's all different risks for children, for vitamin balances, mineral imbalances. They're not going to grow they should because of cancer, HIV, sickle cell, cystic fibrosis, not being able to eat certain foods, low birth weight, celiac disease. There's so many things that can limit a child's ability to get the nutrition they need. Now, celiac disease is all about the small intestines, and there is a problem with fat malabsorption. The celiac inside the child with celiac disease, when it gets the foods, wheat, rye, barley, oats, when you eat it, these children go in this severe cramping, bent over, crying abdominal pain from gluten. Gluten is that they can eat all they want of something else. I mean, they have to be careful with fat because they don't digest it, but they can eat all foods, but they can't eat wheat, rye, barley, and oats. Children can do really good with it, but still with this child, they have an issue with fat malabsorption, so we can't eat too much. And if we do, they'll have something called steatorrhea, which is very pale. It is just big, and it's just really a horrible smelling stool. I had one little boy I had with celiac disease, and it was, you're trying to hold a straight face, but it's really bad because they're not absorbing fat. It's nutrition. So you need to do high carb, high protein, right? Low fat because their abdomens are going to be get distended and gassy, and it's just going to come in their stool. So we don't want that. They also lose a lot of their fat vitamins. This is part of it, okay? So we got to be very aware of the vitamins, that are fat soluble. Again, it's lifelong. It's something you don't treat and goes away. And one of the things that they're using a lot now to instead of wheat, rye, barley, and oats, is rice. And they're doing flours with it, etc. And it's worked well. And today, walk around the grocery store. How many things you'll see gluten free, gluten free? 30 years ago wasn't there. So people with celiac disease have a better chance of taking care of themselves without guessing like they used to. Now, food allergies can be a problem because that means that food that the child's eating is not being used right, and the body's not liking it, and it's showing you some way. It could be that lactose intolerance where now you're vomiting, diarrhea, and gassy abdominal pain. Okay. Remember that when they're allergic to things, that there's going to be another side to it. Like if you can't have milk, you got to be careful. Vitamin D and calcium. We need to replace that in another way, another food group to help with it. And it's the one thing I want you to remember with allergies. Your iron deficient anemia, like that's one of those things. So it's something you need to replace. So you give all the iron foods. If you're allergic to foods, like that milk or high fats you're allergic to, you got to replace it to make sure that nutrition's where what you want that child to have. So they gain weight and they're not failure to thrive. So in GI function, we see problems. They're not growing because they're spitting up every meal, losing calories. They're having diarrhea. They could be having abdominal pain, a distension. That's all that gas in there, right? Jaundice, and we have some things about jaundice, biliary atresia, problem with the liver. And then dysphagia, dysfunctional swallowing, DeGeorge syndrome. That is the big thing. They don't know how to eat and swallow, and they have to work really closely with speech to learn how to swallow their food. And many of those children end up with a gastrostomy tube. Yeroban, another one. So a lot of GI dysfunctions, we're seeing. And we know a fever causes not enough, a lot of fluid being lost. So again, GI dysfunction, we need to replace the fluid. Again, going to dehydration. So dehydration is when too much is going out and not enough coming in for whatever reason. It could be you're sweating, could be urinating a lot, diarrhea, vomiting. Ketoacidosis causes dehydration. It's another reason why we give fluids before insulin, and of course, burns. I love these pictures of these dehydrated infants. You can really look at them, and I'm going to show you what I see. That top picture has a big sunken fontanelle. Looks like they're sitting there quietly. You can even see where the bones in the brain goes, right? Also, look at the color of the ears and the nose. Very pale. So you know that this kid is dehydrated. The child down below, not as bad, but still is that fontanelle sunken. So dehydration, I love infants and trying to figure out, are they dehydrated? I can tell, oh, let me feel that right there. Quickly, I can know what's going on. So what are the other things about dehydration? Well, infants will have a sunken fontanelle, and that's at rest, okay? It can go level when they're crying. That's normal. A normal infant would be even bulging if they were crying, but you should see it, a little bit sunken if they're dehydrated. Elevated heart rate. You're going to have a low blood pressure, prolonged capillary refill, tenting of skin. You're going to see less urine diapers, less output coming out. And then I think it's sad when an infant cries and there's no tears coming out. You're like, oh my God, this poor little baby's crying and there's no tears. I mean, and we know dehydration leads to kidney failure, right? So we really need to get that fluid back quick. So how would we get fluid back to a child with, looking this bad dehydrated? At this point, if they're vomiting or diarrhea, they both need quick replacement. So you're going to start an IV, getting a basic metabolic profile. I want my baseline. What does it look like? Always remember when you're giving fluids, adult children don't matter. You're going to be giving no potassium, and no dextrose in the fluids that you are bolusing, okay? And they say even after we start the regular fluids, unless we have a potassium level and we get the okay from a physician, they don't even want you to put that little bit of potassium in the IV until they void. Always, you're going to treat the symptom. Yes, they're vomiting. Okay, let's give an antiemetic. Now let's take it a step further. This child was admitted to the hospital. 3 days later, how would you know, beside the overall assessment looks better, if that child's what we did worked? Well, what are we doing? Dehydration, replacing fluids. Where would we see that? We would see their weight being more than it was on admission. And it's as simple again, looking at fluids, intake, output, daily weights, they all work together. There's always to look at the intake and output. I've gone over all of them. And then diarrhea, there's all different reasons for it. So how do we treat diarrhea? Well, depends on patient condition. Now, diarrhea, they're able to drink, usually, unless they are lethargic because they're so dehydrated. Then, of course, you would give an IV. But overall, let's give them an oral electrolyte solution of some sort. Pedialyte, Gatorade, Powerade, one of those. All of those things work, okay? And what we say with diarrhea, if you don't start giving food, the diarrhea is going to still be diarrhea because there's nothing to make it solid. So you need to start introducing foods. And do you know what the doctors send these children home with? A lactobacillus every day until their stools are solid enough. And that's treatment for diarrhea. If they continue fever, other changes, then they say come back in. Now, constipation. Now, children can be constipated and they can go 7 to 10 days without having a stool. And many times it is some sort of psycho-emotional something going on. It could have been that their best friend moved away, or their dog died, or their brother is getting all the attention because of whatever, and I need attention. So they will hold their stools. It's the only thing they can hold. So as we're looking at constipation, we need to look at not just nutrition. We need to look at, is there anything else going on with that child? Now, constipation in the newborn child, I've sort of put some mention to it when we talked about thyroid problems and meconium with cystic fibrosis. When you have an infant who has not passed the stool within the first 24 to 36 hours, they will be tested for these 4 things right here. They'll be tested for, well, is an intestinal obstruction, atresia type thing. Okay, that's absolutely structural. The second they're going to look for is something called Hirschsprung's. I'm going to show that to you in a couple of slides. It's basically a structural thing. I'll go into it. But look at this. Hypothyroidism. If they haven't passed the stool, you're going to be doing thyroid levels. And then it could be a meconium ileus, means the bowel stopped working because of cystic fibrosis. So if we don't know a possibility of CF, we'll be doing a sweat test. So those are the things when you see an infant not having a stool this quickly after birth, they're going to be testing to rule them out. Now, constipation, yes, can happen with children for just normal reasons. We know that a child who is on a formula has more chance to be more constipated than a breastfed infant. They also say that as the kid gets older, increase the roughage in the diet, of course. As we get to that 6 months, we can choose, foods. I mean, whole grains, we're starting to do that at 6 months. And then, of course, black beans, they can be introduced going up after 6 months and introducing them. So there are things we can do to alleviate it. They never recommend you to give enemas to these children or laxative. Maybe if it's a very resistant, some Miralax, that's about all they'll order. Enterobiosis, pinworms, tiny worms, and kids get them usually for playing outside in dirt. And it gets under their nails, these little eggs, and then, of course, everything in their mouth, their hands, and then these eggs hatch, and then these children complain of perineal itching right around their anus, itching, and they're not sleeping because they're itching. So these parents need to get a little flashlight, go underneath the covers, take a piece of Scotch tape and put it and touch it to the anus and then pull it off. And you'll probably get one of those tiny little things. Put it into a little container. They can bring it to the doctor and they can show it to them. So, what's the treatment? Well, there is medication that can be given. If one of the kids, the family has it, most likely the family has it. So you need to check the whole family for worms. And the preventative is, again, keeping nails short, keeping them as short as you can, because that's where they come in from. And yeah, you can even put wash hands when they come out inside from playing. That could be part of it. Children do get peptic ulcers. They are these worriers. So they worry about everything. And usually they'll just start with something like diet and then maybe put them on an anti-gas or a gastric acid reducer. Now, it's not Zantac anymore. It is Pepcid, but the book still had, ranitidine there. So Zantac I put there. But just good old Pepcid. Rarely have I seen anything more than that. Hepatic disorders, problems with the liver due to many different reasons. What would we do? How do we take care of a child with, a hepatic sort of disorder? Well, it's all going to go down to diet. How do I feed a child that has a liver problem? You can't do anything to change, what's going on with the liver with these things, but you can maintain nutrition. Again, what does bile from the liver digest? It digests fat. It's another fat one again. So these children, if you give them fat, they're not going to digest it. So they're going to have that abdominal distension, gas, and those greasy stools. So high protein, high carbohydrate, again, maximizing the many calories for that child. Now, biliary atresia. This is where the connection from the liver to the small intestines, which is in the duodenum, and it's not connected and it's not working. It's just a string with no opening. And you don't have the bile from the liver dripping into the common bile duct, to give the bile for digestion. So the bile goes backwards because it can't go, forward. When it goes into the blood. And this is where you'll see the child who's the yellow eyes, that yellow pigmentation looking, okay? The treatment is surgery. You need to connect the liver to the small intestines. Now, what we see initially in these children is no bile is entering, the digestive process. Your stools are pale. That's the big thing with them. These pale stool. Also, the urine is going to get that bile in it. It's going to be, more dark and golden yellow. Now, here's your Hirschsprungs. This is the one that we're going to check for if there's no stool at birth on an infant. And there's an area in the large intestines where there is no nerves. So aganglionic means no nerves. When you put stuff in there, it stretches, it doesn't feel it, and it just sits there. No peristalsis can take place. So it's a non-functioning piece of intestines. Now, sometimes a little bit of stool can squeak out the bottom, and that's like putting it into an icing you'd put on a cake. That little squiggly line, they call it ribbon-like stools, can be coming out of there. This is another thing that affects Down's children. We already know that there is leukemia. We know that they can be affected by hypothyroidism. They can be affected by Hirschsprung's disease. So children, Downs, there's a lot of things to check them for. So when we suspect no stool, this is the first, we're going to look at the Hirschsprung side. We're going to do an x-ray. First look, let's look what the intestines look like. When we suspect, okay, do a rectal biopsy. It shows no nerve, so that's your confirmation. They will do a surgery. It's either putting a colostomy that'll be changed up and put back before they're a year old, hopefully before they're potty trained is what we want to do. But sometimes we can do a pull through where we can take it out, pull it in, reconnect it, and they never have a colostomy. The thing post-operatively with these children is we've worked on the intestines close to the end of the bowel. We no rectal temps on these children at all. And because it's really an intensive amount of manipulation, they're not going to eat for several days post-op. So appendicitis. The cecum, that point in between the small intestines, large intestines, the appendix says, I'm not happy anymore, and gets angry and wants to burst. And your signs and symptoms are that right lower quadrant pain, McBurney point, that's where it is. And we're going to do an ultrasound. The ultrasound's going to say, yes, you're an appendix. So as a nurse, what are we going to do? Well, immediately, these children, when you even suspect an appendix, put them down for, put them NPO so that they cannot eat or drink because they're going to go to surgery. They need an IV in and whatever pre-op meds they need to get, and they'll be going to the OR. Now, sometimes right before you get to the OR, the pain stops and they go, oh, it doesn't hurt anymore. Well, the appendix burst, so now you have peritonitis. So how do you take care of peritonitis? Well, just think about all of this really caustic material has been let loose in your abdominal cavity, and your whole intestines and intestinal wall is now angry, and it's just swollen. So NPO, leave the intestines alone. You'll also have an NG tube. Let's remove that gastric juice so that that's not bothering your intestines. Let's let that heal. Absolutely IV antibiotics because you have an infection going on. Watching that CBC, is that white count coming down every day? Of course, good IV fluids, whatever the physician orders. And the one thing we forget, that abdominal wall where they did that surgical closure was infected by all of this stuff. And it's what we call a dirty wound closure. The chances of it dehiscing are great. So make sure we're checking that wound so it's not slightly opening and we didn't see that happening. Also, because the irritating in that tummy and it hurts, they don't want to take deep breaths and cough. Of course, always medicate for pain first. That's always number one. But how about blowing bubbles? I'd have kids doing this. I work night shifts, so I used to do things like blowing bubbles with kids or taking a straw and doing spitballs on those children with really bad lungs and making a sign, and we'd play together trying to see who would win, get the closest to the middle. It's 3 o'clock in the morning and I'm doing pulmonary care, and these kids' lungs would do great with it. And of course, you could blow it a pinwheel. Younger kids, they liked it. Now, omphalocele, gastroschisis, These are all where part of the inside of the abdomen didn't get in there before it closed up around the bottom of it. So the midline again, the insides are out. It could be any organ. It could be liver, intestine, stomach, all of those things. And it's up and out, and it's usually in a sac. And it's that sac is the peritoneal sac. So again, as a nurse, what is our big thing with this? Well, again, protecting the skin, making sure the skin integrity is kept underneath that dressing, that sack of body parts, and that we put wet saline dressing sterile on top of that. And then the surgeon will come in, and from there on, they'll be doing their dressings. But your job initially is to keep it clean, as infection free as we can. These children will be on their back. They cannot get on their bellies. They won't be held until physicians see them, but usually not until after they can place that inside. Because of the infection risk, they're going to be put on IV antibiotics and, of course, IV fluids, and they will not be eating. Another one you've never heard, intussusception. The intestines climb in on each other. The youngest age I've seen was 5 months. They're usually that 2 to 3 year old. Boy, girl, doesn't matter. Usually the parents are holding these children and their legs are they're just kicking and they're crying. Their backs are arching and they hurt. And the parents say it was sudden. All of a sudden they started kicking and crying and then they stopped. Oh, and then they started doing it again. Well, when I hear all of those things, it puts my clue to intussusception. So what do I do to check? Because there are checks. That is, go look inside the diaper or inside the underwear. You might see like a clear current jellies, like jellyish sort of secretion, maybe a little blood in it in the diaper. And that's telling you it's sort of pushed out this from the intestines. So what do we do? Well, we've got to diagnose it. Goes to ultrasound. Many of them already have come out and they're fine and they don't have an intussusception. I have seen most children be discharged back home with an increased fiber diet to help them. I have seen children that it was sucked in there really hard and they had to do what we call an air enema, where the radiologist under fluoroscopy inserts a catheter up the rectum and makes sure it's tightly sealed and pumps air and watches the intestine pop out. I've seen that many times, and usually that will work. Only once have I seen them have to go up to surgery and get a piece of intestines taken out. Meckel diverticulum is basically a remnant of the fetal mesenteric duct. Okay, what is that? Well, in the small intestines, there's these little outpatching areas. And in that little tissue outpatch is big blood vessel for such a tiny little tab. And what happens during normal peristalsis? It rips. And what you see is painless rectal bleeding. Now, if it continues, you might see an intestinal obstruction. You might see slight tenderness, but usually it's that red blood that's coming out that doesn't hurt anywhere that the parents bring these children in for. They go to surgery, they get the diverticuli out, and these children do well. IBS, ulcerative colitis, Crohn's disease. We know ulcerative colitis is bits and pieces, and you might see all of a sudden this profuse diarrhea on them. Usually we treat them with diet, it's always number one. Medical treatment could be steroids. With ulcerative colitis or Crohn's, maybe they're giving some sort of biologic. Humira seems to be the big one I've seen with that. And of course, because they're not digesting right, many foods they can't have, nutritional support is key. Short bowel syndrome is when, for some reason, the child's lost a large piece of their intestines. Now, when infants are born, some of them are unable to eat initially due to usually respiratory. And we could either give them a tube that goes into their nose and or mouth into their duodenum, or give it from the mouth or nose into the stomach. And sometimes they're very sick kids. And what happens, there had been some sort of hypoxic episode, and the intestines all of a sudden doesn't like the feeds that's going in. It's one of the reasons why we look for, every time we're about to feed a child, or when we come on and do our vitals every 4 or 6 hours, we're going to be checking, is there any aspirates in there? Is there extra food in where it shouldn't be? And we'll be measuring abdominal girth. Now, what happens sometimes is, due to that hypoxic episode that hits some area in the intestines, gets upset and just dies. And it's called necrotizing enterocolitis. And it could be a small piece of the intestines, or it could be extra large. The one patient I had, little Jessica, was one of these post-operatively. She was on a big ventilator, and she had a little feed going on. The intestines didn't like it, and the intestines burst, and she had necrotizing enterocolitis. And she lost, I think the number was like 58 centimeters of the small intestines, which was almost her entire small intestines. So, short bowel syndrome is they're not getting nutrition because there's no areas to absorb all of it, all that lost space. Okay. So, how do we do that? Well, we got to feed them some other way. So, we're going to be giving them, usually, we'll put a Broviac line in. They'll having hyperalin lipids, during the night and during the day. A lot of times, we'll even put them on gastrostomy tube feedings, and orally if they want. We're trying to give them as much as they can. Hernias can be anywhere. I like the belly buttons. I always like to push them, those squishy ones. Those are good. The problem with a hernia is that the issue could happen is if it's anywhere, usually the umbilical or the inguinal hernias. If it becomes hard, tender, and painful, that is what we call an incarcerated strangulated hernia. It's twisted. It's telling you blood has stopped going to the tissue, that intestines. We need to open it up, untwist it, get the blood flowing back so we can save intestines. So that's an incarcerated or strangulated. Sometimes we have no anus at birth, and that's called an imperforated anus. So there's no way we can do a rectal temp there, is there? We can't. We know that there's fistulas. There's fistulas that go from the urine to the vagina, from the bowels into the vagina. I have seen even urine coming out the bowels on a boy. So it's when there's a connection, it's not the right place. And many times it's the nurse who finds them. It's something you don't really see at birth when you start looking. Children like to put everything in their mouth. We know that we need to keep things safe. The big thing with this is that every parent should have their control number for any the 24-hour ingestion, where you call up and you find out, okay, my kid just swallowed this, and what do I do? And what's great about it, they'll tell you to go to the hospital, and they follow up all the time. As a nurse, I would call them up, the poison control number, and I would call them up. In fact, I got to know who they were after a while, and then they'd call back, so how that kid's doing. And they would give you the most up-to-date information. So we do not recommend vomiting anymore or Epicac. There is other treatment that we do use. So giving all the parents the poison control number is what we should do. Now, vomiting, it could be a little bit, like I said, or it could be a lot. Again, remember, vomiting could be benign, that normal reflux types coming up. If it's something that's a lot more than usual, let's look for signs of dehydration. If it's a little child, we can look at their Fontanelle, right? And of course, heart rate, blood pressure, capillary refill, urine output, et cetera, et cetera. Again, always remember, bolusing saline, never with sugar, and we don't ever bolus with potassium, or we don't give potassium until we know a level, or until they do void. Reflux, big thing with babies. It's they're losing a lot of calories. So, and sometimes reflux goes on into being small children. And small children, those are the ones that are having reflux. It's going, the little mini aspirations are going on. So you'll be seeing them after they eat with this little chronic cough. They are little having many aspirations going on there. And that heartburn that's going up. They should be treated, of course, with diet if they can. If not, medication, something to decrease the amount of acid in there. The other thing that they will tell you is the end of trying everything is the surgical intervention called a Nissen fundoplication. Now, have any of you had a patient that had a gastrostomy tube? They always do gastrostomy tube with Nissen fundoplication. That's to prevent you from vomiting. It pulls over the end of your stomach up onto the esophagus so it can't be vomiting. So what does that do? It saves the food for that infant. Now, infants, the first thing we do is we'll start to thicken their cereal, their foods with some rice cereal. And we could give it's not used for nutrition, but they're keeping all their down now. So they aren't getting that nutrition. Always never overfeed, always burp well, of course, keeping them elevated after sitting, elevated after they're feeding, so that if they burp, they can get it out easily. Now, one of the vomitings that is a surgical intervention is something called a hypertrophic pyloric stenosis. This is 7 days to 3 months. It can happen. And the pyloric sphincter is that part of the stomach which connects to the small intestines. And it gets thickened and it doesn't allow milk to go down into the intestines. And the baby eats, they're happy, they eat, yum, yum, yum. And then all of a sudden their stomach is full, it can't go down. So they projectile across the room, vomit. You can pick this child up, point it to a garbage can 10 feet away, and they will hit the garbage can. It is that forceful. Now, when I hear that it's a forceful vomiting, the next thing I do is I put my hand underneath their xiphoid process. And right underneath, I'm going to feel this olive size or marble size little hardened mass. That's your pyloric sphincter. So I know for sure that's going to need surgery. So what do? Well, these children, if they eat, they're just going to vomit. So make them NPO and give them some IV fluids if they're going to be a while, because they're not getting fluids, right? And they just diagnose it with an ultrasound. Cleft lips, cleft. When we have cleft lips, it makes a really difficult time with feeding. So we have a lip and we have a palate. The lip, we're going to probably try to correct that and close it up within 2 to 3 months. And that helps putting their lips around a nipple or around a bottle, okay? And we put that what's called a Logan bow there. So when they smush their face, they can't tear up that incision line there. It could be anywhere, this lip or the palate. I mean, it's all over. We know sometimes it looks pretty at birth. You look at these children and it's difficult to imagine, but look at the difference. And can you imagine a parent seeing their child with a cleft lip? So as nurses, helping them understand that, oh, he's so cute. Once we fix that, he's going to be even cuter. Or, oh, beautiful curly hair. I always change the subject, to try to have them focus somewhere except for their mouth because they don't know what to do with it. Of course, then we teach them what to do. The palate, we usually somewhere between 6 to 12 months do try to get that repaired because if you don't have a good palate and lip, you're not going to enunciate foods well. So the words that come out are going to be more garbled, like, it just doesn't feel right. So when do we start talking? By 12 months. So when do we try to get this fixed by? By 12 months. It has a profound effect on their speech. So the sooner we can get that fixed, and then of course give that speech therapy that they'll probably will need, and they'll do well. Again, there's problems with feeding. They can't clamp around a breast. This is a Helberman bottle here. It was made by a parent. And that top area is soft. This whole bottle is soft. And you just turn it over and the milk goes in and slowly you're holding and you're slowly as trying to make that baby, look like they're swallowing, and you're trying to mimic with squirting a little bit of milk in there. And these kids do really good with it. It takes a lot of time and energy. So you got to be careful, making sure that they're not spending too much energy and they're still growing. Now, another condition, esophageal atresia, tracheoesophageal fistula. This is when the opening from the esophagus doesn't go anywhere. It doesn't connect to a stomach. It's without. So fluid goes down and it comes back up. And when it comes back up, you have a chance for aspirating in your lungs. Second one, they're very common, usually together. Some could be alone, but could be together, is a tracheal esophageal fistula, which means there's a connection between the trachea and your esophagus. So you swallow down your esophagus, it goes across into your lungs, and now you are aspirating. So this child at birth, what it would look like. Well, when you're born, you have mucus in your mouth. You still swallow normally your mucus. So this infant will be gagging, coughing, and they'll be bluish because of all this gagging and choking that's going on there. How do you treat these children? Well, the airway's number one. We want to try to keep the airway clear. So having suction at bedside, head of bed elevated, nothing by mouth. In fact, let me take that back a step. Give them a pacifier, but nothing fluid by mouth, okay? Because these children are still swallowing a little bit of mucus, they're having mini aspirations. This child will be given IV fluids. Yes, that will help with that fluid, but antibiotics also, because we want to prevent that aspiration pneumonia. So tracheoesophageal fistula does need antibiotics, whereas the vomiting of pyloric stenosis does not. That only needs to be NPO, IVs. Tracheoesophageal fistula needs to have the NPO, IVs, and antibiotics. Any questions? A lot of stuff. I told you there's a lot of crazy things in pediatrics that you've never heard of. So let's go ahead. Let's get our Kahoots done. Who wants to win? Javante, you're due. I haven't seen you win yet. I'm ready. Big Mike McCoy. I like that. All right, let's get going. Week 8. A multi. All of the following are signs of dehydration in an infant. So, yes, you would see decreased urine output. So, dehydration, the fontanelle's going to go down, all of that stuff. Elevated heart rate, decreased blood pressure, decreased urine output, tenting of skin, and goes on and on. And dehydration is scary in children. What is a priority treatment for a child with dehydration due to profuse vomiting? So if you're vomiting, you can't eat. So, and you're saying profuse vomiting, this child needs to be NPO, start IV fluids, and given an antiemetic. What is the treatment for an infant with diarrhea lasting for 4 days? So when we're talking about diarrhea, remember, unless it is a uh, child that is severely dehydrated, we feed them orally. That would be Pedialyte, Gatorade, Powerade, one of those things. If it was the child was in severe diarrhea, then it would be IV fluids. What acid base imbalance might you see with a child that is having profuse diarrhea? So let me show you some acid base questions, and these are the ones that you will see. So if you're having diarrhea, what is the type of liquid that you are getting rid of? It's all of your digestive enzymes. It's all alkaline. What are you left with? Metabolic acidosis. You're getting rid of alkaline, you're left with acidosis. Now, what would you have if you had profuse vomiting? You're losing all the stomach acid. So your acid is gone. All you're left with is alkaline. Many students don't get that. That's why I go over it, right now. I'll multi. If an infant has not passed the Meconian stool within the first 24 to 36 hours, what would you assess for? So, not passing stools, our big thing is hypothyroidism, cystic fibrosis, Hirschsprung's, and some sort of intestinal obstruction, etc. We're not really concerned with electrolyte imbalance. That's not what we're thinking about. Deficiency of vitamin D causes. Well, vitamin C is scurvy. I remember that with the pirates on the ship, right? They used to take oranges with them to prevent it. So vitamin D is rickets. And rickets has to do with bones and bone shaping, okay? It's an important concept. Vitamin D, bones, bone growth. Multi-select. What treatment can the nurse anticipate to a child unable to drink or eat anything with profuse vomiting and diarrhea? They can't eat or drink anything with profuse vomiting and diarrhea. How would you treat this one? This one is IV fluids, absolutely. And because we always want to know where we're starting, especially on these sicker children, that basic metabolic profile. Very good. We're not going to feed profuse vomiting. A multi. What nursing management would you anticipate for a child with a ruptured appendix postoperatively? So you've had this appendix burst and spew all of this debris into the peritoneal cavity. Now, what is your big concerns here? So we're going to have NG suction to keep that intestines, from being bothered, IV antibiotics. Yes, we're going to look at that surgical site because it was a dirty wound closure. Now, we want these children up out of bed. We want them coughing, deep breathing because of all that irritation in their belly. It's going to make their lungs get lazy and want to have all this bronchial lectasis, right? So up out of bed, of course, after medicated for pain. Passage of urine, usually at night, in children who should have voluntary bladder control. So that is called enuresis. Enuresis, being to bed at night, right? And some children have it later on. Again, if it just starts to happen and they've always been potty trained, there's a reason why. That's what you should be looked at. Multi. What is Hirschsprung's disease? So Hirschsprung is basically a megacolon, which means the intestines start. But it's aganglionic. Remember, there's no nerves in there. So there's no paracelsus, nothing's going on with it. So yes, congenital absence, and it's called a megacolon also. We need to remove it and do a pull-through procedure. When teaching parents about Hirschsprung's disease, the nurse would include what? How do we treat Hirschsprung's? So we know Hirschsprung's causes a bowel obstruction. We know we're going to have to monitor bowel obstruction, bowel habits to make sure that they're moving. And many times it's a two-stage surgery, but it can be a pull-through, okay? And we do not treat with laxatives and enemas anything with children. We don't treat even constipation with laxatives and enemas. What types of stool does an infant with Hirschsprung's disease have? Remember, it's this big outpatching with this tiny little end that might be squirting a little bit. That's about all you'll see. And it's called ribbon because a little bit might come out of there. What is because which is a condition that occurs mainly in children when the intestines telescope into itself. And that is your intussusception. Again, we're looking for current jelly stools in that one, and it could be suddenly gone and they go home just on extra fiber, or they might need up to the point of surgery. A multi. A 2-month-old infant has GERD and has been treated by thickening formula. How do you know it's working? So you've done something to help a child that's had this gastroesophageal reflux going on. And that little spit up. And they thicken the formula. What's evidence that shows you it's working? They're going to be gaining weight and they're not going to be spitting up as much. Very good. Can you decrease the incidence of enterobiasis in children? So keep the fingernails short. I mean, hand washing is always everything, but in this case, keep their fingernails short if they're outside playing in the yard in the dirt. What are signs and symptoms of enterobiasis? Itch, 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 and they're not going to be sleeping also. Very good. Gastroesophageal reflux disease. And that's the stomach goes back in the esophagus. You know, young kids will that are older are going to have a cough, and they're going to have that pain in their chest because it's all that reflux going on. Infants will arch. You'll feel their back, they'll arch as they're refluxing. What would the nurse be looking for when a patient has meckel diverticulum? Remember, that's the small intestines. They find it and they do a surgical repair. It's painless rectal bleeding is usually that symptom that they usually come in for. A 6-year-old child goes to the ER due to abdominal pain, fever, and vomiting for the last day. What assessment is priority? What do you need to know? Tell me about the pain. Is it like where your stomach is? Is it in the belly button or is it right lower quadrant and now it's the appendix? Where it is depends on the care of the child. So knowing where it is will help speed up a process if they have to go to the OR before the appendix bursts, right? What would the nurse expect to see in an infant with biliary atresia? Biliary liver, atresia, A without, no connection of the liver to the common bile duct. What would you see? Bile's going the other way. So clay colored stools, abdominal distension. Yes. And you'll see that golden urine too. What structure of the mouth can be impacted by cleft lip and palate? It's all of them. You know, the hardest one is the lip is easier to work with than the palate because a child that doesn't have a palate, when you're feeding them, it goes up through their nose. So you have to be really careful feeding them. Cleft lip repair is typically done when and that's somewhere between 2 to 3 months. That's the lip. We first do that. Then the palate is done before 12 months, at 6 to 12 months because of speech. When does cleft lip palate the cleft palate repair typically get done? I mean, I love the pictures and how you see that go from, a big cleft lip to you can't even barely tell. And yes, it's 6 to 12 months. Esophageal atresia. So esophagus with an A, esophagus A without. There is no connection to the stomach. Yes, they can, hook that back up. And the tracheoesophageal fistula, they can remove the fistula. So they are easily taken care of. And these children are usually normal cognitively. They're usually normal children. It's just that it wasn't formed correctly. What are classic signs of esophageal atresia and tracheal esophageal fistula? What do you see when they're born? So the olive shape is your pyloric stenosis. Current jelly is intussusception. And cyanosis, choking, coughing. They can't swallow. It's going into their lungs. Is esophageal, tracheoesophageal fistula. A multi. Neonate suspected tracheoesophageal fistula. Nursing care should include. I mean, always remember this is a child who, shouldn't be eating, right? Make sure we give them a pacifier. This is one of those cases that's the way that they soothe themselves. Remember, if they are fed, they're going to gag and choke. So elevate the head of the bed and keep them NPO, suction at the bedside. This is the one with many aspirations, needs IV fluids and antibiotics. Very good. A 5-year-old child is complaining of epigastric pain and a persistent cough. What would you suspect? What is that pain and a cough thing? That's going to be your gastroesophageal reflux. That's reflux going on because remember, it's going up and down. It's the mini aspirations, and that's what the cough is. Okay. Remember, aspirations is a cough. What is ranitidine used for in a child with peptic ulcer disease? As I told you, it's now called, the feminine, which is Pepsid. And it just takes and reduces the amount of gastric acid production. It doesn't neutralize it. It just says, stomach, let's slow down a little bit. It's not giving enough. Too much. Signs and symptoms of a hypertrophic pyloric stenosis. So, hypertrophic pyloric stenosis, the valve that connects the stomach to the intestines, is thickened and nothing's going through there. What would you see? Well, you're going to feel that valve, that pyloric valve, and it feels like an olive. I call it a marble. Same sort of thing. Very distinctive. Signs and symptoms of a hypertrophic pyloric stenosis. Would that kid show you? Honestly, these kids would come in, they're young, say they're coming in with vomiting. I have the first question. Is there vomiting spitting down or is it across the room? That's all I want to know. And if it's spitting down, I'm reflux. We're safe. Pyloric stenosis, projectile vomiting, that one child's going to go to the OR. And they have a great appetite, but they keep vomiting and then they want more and they eat more and then they vomit. So they keep eating if you let them. Preoperative treatment for pyloric stenosis includes I was telling you the difference between pyloric stenosis and the tracheoesophageal fistula. There's two different treatments here. We don't worry about this being any aspirations. So this one is NPO and fluids, okay? What does the celiac disease affect? It's all about the small intestines. It's all about fat digestion. It's all about gluten intolerance. Wheat, rye, barley, and oats. If you have celiac disease, what should you eliminate from your diet? You think about these children, they still can have ice cream, they still can have chocolate, they just can't have certain types of breads. And there are all sorts of different supplements today to give them. Priority nursing care of a child with a ruptured appendix post-operatively. Priority. What do you do first? What's their main priority? Antibiotics, because you have to fight the infection. Yes, pain is good. It will help with, getting the child up and out of bed and prevent other complications. But your priority is antibiotics when you have appendicitis, that peritonitis. A multi. How can you assess the effectiveness of fluid replacement for a child with severe dehydration? So we're talking fluid balances here. How do you measure fluid balances? So heart rate is normal now. Capillary refill is now less than 3. Blood pressure is within normal. And the big thing is weight. The weight has maintained, or they're not losing, or they're gaining a little bit. Okay? Yes. A multi. Vitamins that children with celiac disease are prone to lose. So I'll tell you, that's fat vitamins. Which one of these are fat vitamins? So remember, they don't like fat. They lose it. They have steatorrhea, these bulky, foul-smelling stools. And everything but vitamin C was the answer. What foods would you select for a child with celiac disease? So no wheat, rye, barley, or oats. They can have everything else. So they can have eggs, they can have fruit, they can have milk. Everything else has some sort of bread product in it. Phimosis, what is that? So phimosis is the opening on top. It's too tight and you can't pull the foreskin down. How do we treat it? Usually with a circumcision. What is a hydrocele? Remember that usually will go away by itself. If not, we'll do surgical repair. And remember, always any surgical repair in that area, we need to protect that child post-operatively. Children have no filters. They'll go ride on their bike or their tricycle, and they shouldn't be doing that. A hypospadias is So we have hypo and epispadias, and which is which, right? So hypo below is on the ventral side of the penis, okay? And then we have the dorsal is on the epispadia side, the top. What is cryptorchidism? Again, that's when the testicles don't descend. You suspect an infant has cryptorchidism. How would you examine this infant? And that we have them in a warm room. You have them in a cold room or take that diaper off too quick, it gets cold, testicles will suck back in, and you're not going to get a good exam. Another thing you would ask, if you're not finding a testicle, you would ask the parent, has a healthcare provider before been able to feel the testicle? That's an important part of it. A multi-select. How is a hypospadias corrected? So they use the foreskin as a plastic closure. They put this catheter or a stent in postoperatively to keep that lumen open. It is a fillet of the penis and open. It is general anesthesia. It is a major surgery. So it is not under local. What is bladder exstrophy? So bladder exstrophy is that midline, the bladder keeps out, and it happens during, growth and development in there. Very good. What is priority nursing care for an infant with bladder exstrophy? So many times nurses are called to delivery rooms when these children come out, and our priority is to make sure that we get that area protected for infection. Also, all the tissue, making sure that we maintain tissue integrity. Anything born on the outside, tissue integrity and preventing infections. What are the clinical manifestations of nephrotic syndrome? So remember, it has nothing to do with kidney failure. It says protein, I don't like you, you're gone, and in the urine gets rid of it. And that is nephrotic syndrome. What happens because of it? You don't have any albumin or protein in your blood. You also are swollen all over, and these children are very prone to infections, and it's something that'll be there for life. Treat it, corticosteroids. Children with nephrotic syndromes are often given what medications for fluid overload? So, what would you give to try to pull fluids out of the interstitial tissue, back with it intravascularly, and get it out of the body? So, nephrotic syndrome gets rid of protein. So, we're going to give protein back by albumin, okay? And we can do it. It goes interstitial into your intravascular. It pulls out fluid. Then about 30 minutes later, we'll give that Lasix furosemide, and you'll see a big urine output. It helps with a lot of the swelling. What is used to treat nephrotic syndrome in children? And it is prednisone. It's usually what's given. A child's admitted with acute glomerulonephritis. What recent illness could validate this finding? And that's a recent strep infection. What is the priority nursing care of a child with nephrotic syndrome? So, how do we figure out anything with fluid? Daily weights, intake, output, daily weights are the big things. Monitor fluids or decrease them. And of course, low sodium are the other things. Why is erythropoietin used in chronic kidney failure? It's because it helps red blood cells and that produces hemoglobin hematocrit. And yes, very good. Multi. Children with chronic kidney disease can have renal osteodystrophy. What can this do to the child? Now we were talking about, you know, um, osteobone dystrophy, which means not done right. And it's because chronic kidney disease, number one, have low blood volumes of many things. They'll have high parathyroids, which is too much calcium. They'll have growth retardation. They're not growing right. And of course, that osteodystrophy has to do with the bones. They're just not being born the way they should. Has nothing to do with uric acid at all, though. A diagnostic finding of acute glomerulonephritis may be. And that is that ASO titer. That is, if you didn't know you had it and they're questioning, did you? Well, that would be a test they would take and that would confirm it without even you knowing that you had a sore throat, a strep throat. Which complication of peritoneal dialysis is most important? You're going to look for this closely. And that's all about that abdominal cavity. It's your only kidney. You've got to be careful. So, preventing infection. So, abdominal peritonitis, we want to prevent. Which clinical assessment is most important to report with a child diagnosed with an acute kidney trauma? I had this little boy come into the trauma room, into the triage area, and he had been playing hide and seek, and he went around the corner, and he's to his back, and a hitch of a trailer hit right at his kidney area, and he had this huge bruise, like huge, and he was in pain. The big thing was we did labs. His potassium was 7.6. He had a ruptured kidney. So yes, that's what we're looking for. And he actually did. She had a fractured kidney. He had to be admitted. What would you do if the fluid draining from peritoneal dialysis has changed color and is now cloudy? What are you going to do? This is our worry of infection. You're going to call the doctor. We're going to give antibiotics, but you need to tell the doctor. No, it's not normal at all. It should still be clear all the time. Call them as soon as you can. Get antibiotics soon. Start it as soon as you can. A multi. What should the nurse anticipate a child who just had a renal biopsy? Well, we've touched the kidney. What are you going to worry about? So, kidney intake output, we're going to look at the dressing for oozing, and we're keeping them on bed rest so that for 24 hours, so that we're not going to have any increase of urine or blood coming out of that and creating other problems. Very good. And last question, what would the nurse provide to an infant that cannot eat normally, like your tracheal esophageal fistula child or your esophageal atresia? What would you give a child? And it's giving them that pacifier. Let them have that for relieving stress and for comfort. All right. Number 3, Kimberly. Good job, Kimberly. Number 2, Kirsten. Good jobs. You got beat out in the end. Libby beat you. It's always a fight. Bree and then Mare Bear. Good job, guys. So week 8 is done. Remember, any questions about that project, just let me know. I know some of you have to wait to the last moment. I'm never upset. As long as you get in time, that's the bottom line. So any questions you have, let me know. If I can get them earlier, I can look through them. If I don't have them early enough, I won't be able to, okay?
So what
So
is,
next,
sorry, how
good.
do you want us to contact you about it? Do you want us to email you? Is that the
You
fastest
can
way?
turn it in right through the modules. Now,
Oh, yeah,
a
that's right.
grade's going to pop up, but remember, we can keep resubmitting. There's unlimited submissions. And as you change what I tell you, you're going to get a better grade. So put it there.